Welcome to the nation. A very good afternoon. You're here with me, Tamina Kausji, and my guest for the day, Dr. Bheena Vyshali Karunyam. She is a consultant obstetrician and gynecologist, and today we're here, doctor, to speak about Pcos.
Hi, Tamina. Thank you for inviting me. It's a pleasure to be here today.
Absolutely. Thank you for taking the time. Right. So anyhow, we will be discussing Pcos, to elaborate, Polycystic Ovarian Syndrome. But before we get started and get down to the nitty-gritty and all the details of what it is, what it isn't, let's actually check out a video that helps us give a full perspective in a nutshell really quickly before we dig in. So let's roll that first.
What is PCOS? Polycystic Ovary Syndrome, or PCOS, is one of the most common conditions disturbing hormone secretion in females. The imbalance of estrogen and progesterone leads to the growth of multiple harmless cysts on the ovaries. Symptoms? Symptoms include unpredictable menstrual cycles, or a failure to menstruate, high blood sugar, infertility, acne, and an increased amount of body and facial hair. Women with PCOS often produce higher than normal levels of androgen, a male sex hormone. They are also more prone to anxiety and depression, diabetes, high blood pressure, high cholesterol, heart disease, ovarian and uterine cancer. Tips to help. Women can benefit by making healthy eating choices and regular exercise, especially if they are overweight. They must meet their dietitian regularly or ask their doctor to recommend a weight control program. Follow us to watch our Yoga for PCOS series this week.
Right, so there you go. So that's PCOS or Pcos just in a bit of a nutshell. Right.
That was a nice video, actually.
Yeah, exactly. I think it's really summed up everything that's important.
It has, actually.
Okay. Now, Dr. Bheena, so tell us a little bit about how did you move from, of course, being an obstetrician to a gynecologist to also your interest in dealing with Pcos?
Okay. Actually, being in the government sector, we tend of don't follow up on certain patients. You see a certain bunch of patients and then it goes to another group of doctors as such. But in private sector now, what's happening is you tend to see the same patients again and again, right?
Ah, I see.
And you, what I realize is there's more than what we actually know, because it's actually affecting a lot of patients at this point of time. You're talking about 1 in every 10 patients that actually walk into my room, they're actually having some form of menstrual problems and all that, eventually being diagnosed as polycystic ovarian syndrome. So it's a very common thing that is going on. So I think it's best that we actually highlight this to the women out there, so they actually know what is it about, what can be done, and literally actually relieving a little bit of their stress and tension. So that's what actually made me or pulled me towards this topic.
Right. Okay. I mean, it's wonderful, and thank you for taking the time to actually go through this with us. And as I mentioned, this is going to be an hour-long focus special on polycystic ovarian syndrome, or Pcos, something which there is still a very low level of awareness of, despite what Dr. Bheena says. 1 in 10 women who she's seen of late actually end up having some form of this. Right. Now, I think what would be good to start off with is also sort of myth busting. Now, is it the same thing, doctor, to be having polycystic ovaries and to be having polycystic syndrome?
No. Polycystic ovaries, you're talking about the ultrasound features of the ovaries, where when you do an ultrasound, you actually look at multiple eggs on the ovaries that are not matured. Yes, that's the ovaries itself. But when you're talking about polycystic syndrome, you're talking about the whole, how do you say, the presentation of the patients, the clinical examinations, including your ultrasound findings as well.
Right.
So it's 2 different things, actually.
Okay. Now, as you said, it's increasing in its commonality and its expression, and we do not have the Malaysian statistics overall at the moment, but American statistics show that between 12 to 18% of women of reproductive age, basically 15 to around 55, 60, actually have Pcos. Now, that's an incredible number, but what's more incredible is that 70% of these women, at least in the American landscape, go undiagnosed.
Right, that's true.
So I think what is very important to start off with is a step-by-step about how would a woman know that she could be suffering from Pcos.
All right. based on my experience, most commonly women actually come complaining of symptoms, right?
Right.
The most commonest one, if you're talking about younger age group, 15-year-olds,
Okay.
they will present most likely with irregular menses or periods as
That's
such.
right, okay.
Alright? So they come in saying that, oh doctor, I've got my periods probably once in 2-3 months. So that is the
Right.
typical presentation of a polycystic ovaries.
I see.
When time goes, then patients or women do present with other complaints such as why is my facial hair becoming more at this point of time? Every time that I take them off, they still seem to be growing. You know, that'll be another common presentation.
Exactly.
Also as well, main bulk of women actually go seek treatment. That's why you're saying undiagnosed, right?
Yes, that's right.
They come and seek treatment only when they decide, oh, it's time for me to start a family and I can't get pregnant.
Right.
You know, then it's a retrospective, you're going back to their cycles, their periods, your examination, and you find that yes, these people are actually polycystic ovarian syndrome.
Right.
And as you mentioned, infertility itself, you're talking literally about 70% of them being the main cause of PCOS, being the main cause of infertility as such. Yeah,
I see.
Then the remainder, of course, I have other issues that actually cause infertility.
Right.
So these are simple things that can actually trigger you to say, oh, am I actually having polycystic ovaries? I've been trying so long to get pregnant, I've not got pregnant. Why are my periods so irregular?
Right.
Yeah? The other thing is, why am I getting pimples? Why am I getting facial hair? All to do with androgen excess, which is more actually common in males.
That's
but
right.
when you tend to get that more, then you have to actually think, am I actually in that group? Polycystic ovarian group? Yeah,
Right.
that should be the thing. The other thing common is weight gain.
Okay.
All right. Most people out there will think, oh, she's just eating and she's just putting on weight, those kind of things, right? But actually, it's not because of habits. It's just because of the resistance of the body itself. They just, whatever they do, whether they're diet or they're having their exercises or strict regimes that they go through, they still tend to put on weight. So this is another thing that you got to actually think of as well, presentation, common presentations.
Right. So now, going back to the first, the first category that you focused on, like the younger age group, 15 to maybe 18-year-old teenagers still.
Okay.
Now, it is also rather common at that age group to still have irregular periods almost as a regular feature of the menstrual cycle. So how does, especially a teenager, perhaps approach their parents or caregivers with the question, do I have Pcos?
All right. Most of the time, you can, from the age of menarche, that's the first time that we get our period. It takes literally sometimes up to about 3 years to 5 years before the menses actually become regular.
That's right, regulation.
As long as it doesn't disturb or you have polycystic ovaries, I don't think you need to actually disturb at that point of time, unless when you're talking about 2-3 years, I mean 2-3 months, and they come with their periods and it starts becoming heavy, that's when you actually need to intervene.
Right.
All right. The other thing is that in terms of, I think teenagers this time they are very cautious about their looks wise and all this, and their pimples and all that. And when they actually get treatment in terms of skin, right, and the pimples don't go down with whatever treatment they've given, then it's time actually that we could actually treat the polycystic ovaries with certain medications that will also treat all these other complaints that they are actually having at this point of time. If not, as an obstetrician, I would actually say, although you're having in early times, as long as it doesn't, I mean, like in the teenage years, leave it alone, right? Let it regularize by itself, unless it's causing some problems. Then you need to seek treatment.
I see, right. Now, as you mentioned, so most women actually go around to getting to medical help when it comes to fertility issues. Right. Now, does that also mean all women with Pcos cannot conceive?
No. That polycystic ovarian syndrome, basically, if you go back to, let's go back to our menstrual cycle a little bit, if you don't mind, in an average, a menstrual cycle is about 28 days.
That's right.
All right. So what happens is, in that 28 days, the first 14 days, your eggs are actually being matured.
That's right.
And when you reach day 14, it ovulates. The second 14 days, by the time, if you don't get fertilized, then it breaks down and becomes your cycles again, your menses again.
That's right.
So in this polycystic ovaries syndrome, basically what happens is your body is producing a little more extra androgens, the male hormones that we were you saw during, that we're referring to. That actually prevents your eggs from maturing. Okay?
I see.
So it actually sort of stays in a certain immature phase, and it takes a very long time to grow.
Right.
That gives your irregular periods.
So that's what we're also showing in a slide on the screen.
Right, exactly.
So you've got the normal ovary on the left, the polycystic on the right, which I mean, just
those are
looking
the
at it
immature
pictorially,
follicles.
yes.
Yes.
So in a sense, it's like a backlog.
Yes.
Within the ovary.
So for it to actually take time and grow, sometimes it can go months, 2 months, 3 months, right? So they might eventually ovulate, but it's just that you don't know when they're going to ovulate. So that's where the the hardship comes in. When are you going to actually try to get pregnant? That it becomes a little bit of a difficulty in timing.
That's right.
In terms of that. So what really happens is that is where we're trying to actually help out, which means they can get pregnant by themselves, but it's going to be just difficult.
Right.
Right.
Difficult, as in aside from conceiving, is it also more difficult for women suffering from Pcos to carry through a viable pregnancy?
Definitely.
Right.
When you're talking about polycystic ovaries, there is something called insulin resistance in the body.
Right.
All right. The body automatically is resistant to basically getting the sugars which we consume into our muscle cells, into the fat cells to help in terms of metabolism.
Right.
So in polycystic ovarian patients, what happens is this insulin just doesn't work.
Okay.
So, they have very high levels of insulin in the body. So there are very high levels of sugar in your body as well.
Okay,
So
right.
when they get pregnant, when you're talking about high levels of sugar in the body, they are a very high risk of actually having early miscarriages.
Right.
Okay. You're also having a higher risk of having literally being diagnosed of having gestational diabetes mellitus, which is diabetes mellitus in pregnancy, which could in fact lead to abnormal, not to say abnormal babies, large babies.
Right. Heavier birth weight.
Heavier birth weights, difficult deliveries, landing up in cesarean sections and all those things as well. So it's not as simple.
Okay.
You literally have to change your whole sort of lifestyle as well during pregnancy to actually prevent all these complications that can arise during pregnancy.
Okay. Now going back to the roots of Pcos itself, because I think at the moment it sounds like you could have it because of all of these factors.
Right.
Now it is also, as you mentioned, a hormonal issue at the baseline.
Right.
Now does that mean it is hereditary or is it something that one acquires because of lifestyle? What is it?
Literally till date, based on all the research that has been done, they just say it's a hormonal imbalance. There are a few research that say, okay, it could be the genetic disposition.
Okay.
Basically, if your mom has it, your sisters have it, then you also have a tendency to get it as well. But that is not exactly the
science.
Yeah, the science to really say that, yes, I am going to get polycystic ovaries.
Right.
So literally, it's just unknown why your body produces that imbalance of that estrogen as well as the male hormones, androgens, that actually cause all this problems in the end.
I see, right. Now, just because as a matter of interest, would it be, could it have anything to do with our current environmental situation or the fact that modern conveniences, chemicals and etc., could it be adding to the incidence of Pcos as compared to say maybe 50, 100 years ago?
Yeah. Looking back in that way, I would say probably yes.
Right.
You're talking about our lifestyle, the food that we take in as well, up till date. So
which
the
also have hormonal destabilization issues.
Definitely.
Right.
What we consume, what chemicals are in your food, the type of food that we eat as well. We're talking about more fat, high fat foods, more carb related foods and all that. So that will actually, to a certain extent, probably worsen it. But to say, is it, we never knew about it previously and now we're just getting more aware about it, but it has been there over the years. These are things that are just going to make PCOS more, worsen.
Right.
Yeah, that's about it.
Exactly.
Yeah.
So the more common PCOS is, so what are some of the classic signs and symptoms that you would try and look for when you have a woman come in for consultation?
Okay. Once they come in, the first thing we're going to ask them definitely will be about their regular menstruation cycles.
Right.
So you're talking about in a year, 12 months, we're supposed to get 12 cycles in a year.
That's right. That's textbook, though.
That's textbook.
Yes.
So you're talking, a normal cycle can range, in fact, shorter, 21 days. It can go all the way right up till about 35 days. That's quite normal for us. In this polycystic ovarian patients, what happens is, because I told you that the immature cells, they don't ovulate, and the lining of the uterus just keeps on thickening, they tend to have prolonged periods of no period. I mean, no menses at all.
Okay, now on that note, let's take a quick commercial break, and we'll be back shortly with Dr. Bheena. Stay with us. Welcome back to The Nation. Still with me, Tamina, and Dr. Bheena, speaking about Pcos, or Polycystic Ovarian Syndrome. So this is for all our female viewers in particular, but not restricted just to the women out there, to the fathers, the husbands, and any family members as well. Right. Now, Dr. Bheena, as we were saying, now Pcos, so what would be some of the classic signs and symptoms to watch out for, aside from irregular menstrual cycles?
Okay. Besides irregular, we're talking about menstrual cycles actually just now, so you're talking about in a year probably 1-2 cycles that they will get compared to us, which are more normal, which will be somewhere around minimum of 11 to 12 cycles a year. All right, so that is one typical presentation. All right. Besides that, we were talking about the fertility issues earlier.
That's right.
That will be the other presentation that they come in with. All right, and of course weight issues. That will be the other thing that they will come in, which we also mentioned earlier.
Right.
Now, when a patient walks in, typically you can actually, there are typical features that you can actually look at a patient and say, yeah, this is most likely polycystic ovarian syndrome.
Right, I see. What would those be?
If you're talking about high androgen levels, so clinical presentation of hyperandrogenism, okay, so you're talking about male pattern distribution of hair. So upper lip having hair, on your chin having hair, sometimes they have hair on the back, all right?
Right, so it's an additional hirsuteness caused
hirsutism,
by
exactly.
the hormones.
Right.
I see.
As well as back patches of the skin. It's called Acanthosis Nigricans. It's basically because of your insulin resistance.
I see.
So you can actually get that over your cheeks, over your hands, your backs, thumbs, all those things as well. So that's another typical feature as well. Central obesity. So instead of, this is more typical of male, females have more tendency to have obesity over the lower part of your thighs and all that. So this is more towards central obesity. So your tummy area.
So basically the girth of it.
The girth of your abdominal circumference, they call it, will be definitely much more.
Right.
Besides that, other signs which include pimples, all right, their BMI of course being in the overweight or obese categories as well.
Right.
So these are typical features that once you can actually have a spot-on diagnosis at times when patients actually walk in.
So it just sometimes presents itself quite classically.
Quite classically.
I see.
Right. If not, it could be just one of those things. That means a little bit more of the hair distribution, just obesity, central increase of your abdominal circumference as such.
Right.
How do we actually confirm this hyperandrogenism is to do blood investigations, literally.
I see, right.
So we take the serum testosterone levels, looking into the main hormones, and that will actually show to be a little bit more elevated compared to what we all have androgens, but it will definitely be more elevated in these patients as well.
Right.
Right. And of course, there's a hormone called follicular stimulating hormone, luteinizing hormone. These are the hormones that actually stimulate your eggs.
Okay.
Right? So when we're talking, they're so resistant, they're immature, they can't grow.
That's right.
So you expect these levels to be actually high as well. Because they're trying as much as possible to stimulate the eggs to grow.
Right, because that is sort of the body combating the hormonal levels.
So that will be the other thing that will actually confirm that, yeah, these are actually in the range of hyperandrogenism as well.
Right.
And finally, going back to that picture that which you showed earlier, ultrasound.
Okay, ultrasound.
So ultrasound, it's typical of, basically, we call it pearl of strings, a string of pearls, basically, the necklace. All right, so it's got that classical look on the ultrasound.
I see.
So it's got that little round fluid, little cyst on the ovaries. So that is also another diagnostic sort of that criteria. All right, but to doesn't mean that you'll actually have all of these things. All right,
At the same time.
At the same time.
Ah,
So
there
you
go.
could actually have one or two out of it, but to confirm that you're actually having this disease, it's 2 out of 3 of these things that I've actually mentioned to you. They must to do with either your menstrual irregularities, clinical features, or your blood investigations,
Right.
plus finally your ultrasound findings
Okay.
of it. So that's how they will actually present. Right?
Exactly.
Yeah.
Now, are there any tests for diagnostics wise, especially the hormone level?
Only these hormones that which I literally mentioned to you.
Right.
Your fasting serum hormone, follicular stimulating hormones, your luteinizing hormones. We actually take the serum testosterone levels as well.
Right.
All right. We also look at the insulin levels as well. So your insulin being very high,
Okay.
as I told you, is one of the culprits of the whole thing as well, isn't it? So you're
Exactly.
trying to
it starts
actually
with the weight as a symptom.
as
or
a
sign.
symptom, exactly. So you're trying to actually bring down the insulin levels or the insulin resistance, and that treatment comes in later, which probably will mention later what you can actually give to bring down your insulin levels as well.
Right.
That will be the, and of course investigations, you're going back to ultrasound being an investigation as well. So
a
that
tool
will be
itself.
routinely done, yes.
Right.
But of course it'll be a bit difficult in terms of being a little bit on the overweight side and obese side. All right.
That's
So
right.
when you're talking about younger age groups, it might be difficult to actually include that, and you might not see it typically. All right. So 2 out of 3, as
right.
long as
2
you
out
get
of 3 at least,
Yeah,
right? And
that's
of course the results of the hormone test.
and the hormone test as well.
Right.
Yeah.
Okay.
Yeah.
Now, generally, let's say if you have an atypical patient presenting themselves, so does that also mean that it's possible for a woman who is of normal body weight or even underweight, as well as she has previously had a child, to also present with Pcos?
If you ask me, 90%, or based on textbook as well, 90% of the women with Pcos actually are overweight. But there is this 10% of the group where are actually not overweight at all.
Right.
They're actually slim. It goes back to basically only the androgens being a culprit in this place, and also with the your follicles on your ovaries again,
Right.
being the culprit and producing more androgens again. All right, but it doesn't mean that your fat or overweight actually typically plays a role in it. But you can have polycystic ovaries in patients who are actually lean as well. We call them lean PCOS.
I see.
Right.
Okay, so lean PCOS and general PCOS.
Yes.
Right. Now, aside from the risk of developing diabetes, what are some other short-term as well as long-term consequences of having Pcos, of living with Pcos?
Okay. If you start off, is actually because it's quite a cause for many things,
Right.
If you talk about general health issues, literally you're dealing with metabolic syndrome. It's another
Okay.
syndrome. Pecos calls metabolic syndrome. So metabolic syndrome is a cluster of problems actually.
Okay.
So you're talking about high blood sugar, high blood pressure, high cholesterol levels. Eventually all these things can actually lead to heart diseases as
Right.
well as heart attacks. All right. So that will be one main thing, which one will trigger the other, eventually leading to possible heart attack and eventually even death in that sense. All right. Also, in terms of when we're talking about the 90% who are obese,
Right.
So you have a tendency to have central obesity, all right? So there is a difficulty in terms of, we call it sleep apnea.
Okay.
All right. So they also have difficulty in sleeping, where at times they actually don't breathe. It's sudden stoppage of your breathing. All right?
During sleep.
During sleep. So that eventually causes all other problems as well. So you're talking about the next day being tired, being sleepy all the time, lethargic, all those things as well.
And
Alright.
how often is it that a person experiencing sleep apnea is aware of it? Or is it just the residual, the next morning?
It's just the next morning being able.
Right,
Yeah.
I see.
There are tests that actually pick up like how many times.
Right, the arrhythmia. Okay.
The apneas that they go through throughout the night.
Okay.
And a person with PCOS who's obese can actually go all the way up to 70 times.
Oh, wow.
Yeah,
Okay.
depending on the grading, mild, moderate, severe as well. And of course, when you have apneas, oxygenation reduces to your brains. So that gives you your lethargic, your tiredness, you know, and your irritability, mood swings, all those things that actually are the consequences next day. So the patients keep, women keep thinking, oh, why am I so tired all the time? But actually, this is what is actually happening, the sleep apnea and all that as well.
Okay.
All right?
So that's a very interesting as well as an alarming side effect.
Yeah,
so
it
something
is.
that might, you know, sort of ring a bell for many people
Many
out there.
people as well, right?
Right.
Then you're talking about, again, fertility issues. That's the other one, your menstrual issues. And finally, long term. Now, when we don't get our menses, as we say in PCOS, 2-3 months once, right?
Right.
Your lining tends to just keep on thickening. Sometimes it's not even ovulation, all right? When your lining just becomes too thick, it just sheds. There's no more blood supply and it sheds off.
Right.
So this prolonged episodes of thickening of your lining, what can happen is the cells within them can actually change. We call them metaplasia. That means they become abnormal cells.
Right.
All right. So over time, they become hyperplasia. That means they just become thickened, and over the years, actually, it can become the uterine cancer. It's called endometrium cancer.
Right.
So this sometimes probably women might just joke and say, oh, I don't get my period very regularly, that's fine.
Right.
You know, I'm happy I don't have to get pads or in that line.
Suffer every month.
The pains and all that. But actually, in the end, you're worrying about having uterine cancer as well.
That's right,
you know?
exactly.
Yeah. So my advice to them always is, although you're not getting your periods every month, you don't want to have your periods every month, at least try to get them about 3 to 4 times a year. So that actually reduces your risk of getting endometrial cancer or uterine cancer in the long run.
Right. Okay. Because in that sense, that's the healthy function of a normal body.
Normal cells. Yeah.
Right.
Yeah.
Okay. Now that's very interesting because so there's also the fact that there's hypertension, there's heart disease.
Yeah.
Now, how do those come in just quickly before we go off for the commercial?
Literally, it's basically because of your insulin resistance again.
Right.
So your insulin is there from the pancreas to push in your sugar into your cells. So when your sugars don't push into the cells and your fat cells, actually, basically fat is taken out through insulin as well.
That's right.
All right. So when your fat is excessive in your blood vessels, it's going to clog up your blood vessels. It's going to increase your cholesterol levels as well.
Right.
All right. So when you have a clogged blood vessels, it can lead to a heart attack as well. And of course, high sugar levels because it's not pushed into your cells. Insulin actually helps this way.
That's right.
So eventually, you get diabetes mellitus as well, which is sugar.
Exactly.
Yeah.
Right. So on that note, let's take a quick commercial break, and when we're back, we'll still be on the topic of Pcos. Stay with us. Welcome back to the nation. Thanks for still being with us here at the studios at BERNAMA. I'm still with Dr. Bheena speaking about Pcos. Now, doctor, so as we were saying, now living with Pcos is of course a reality for millions of women worldwide, as well as a fair number of Malaysian women too.
Right.
Now, what are some of the lifestyle adjustments and changes that help any woman suffering and living with Pcos live more healthfully?
Okay. Going back to lifestyle changes, so, as we've mentioned earlier, 90% of them are actually on the overweight to obese side. Okay?
Right.
I know many of them would have heard the same thing, please lose weight, please lose weight. It's not something that we're actually trying to probably ridicule, or it's difficult to do as well.
That's right.
But that's one of the main things that actually helps out the whole thing. All right?
Right.
Many studies actually have shown that, as a reduction of just 5 to 10% of your current weight, so they say they're 100 kilos, a 5 kilo reduction itself actually helps you regulate your cycles back again.
Right.
All right?
Wow.
So that it's more than enough. So getting there is where I think most of the women have a little bit of difficulty doing. So it's basically back to being eating healthily. All right. So of course, reducing your carbohydrates, increasing more of your proteins, your vegetables, fruits. Having exercises, all right? I'm not talking about going to the gym 3 hours, 4 hours a day and trying to burn it off. It's just having regular exercises. You're talking
Movement
about
more than anything.
movement, yes.
Right.
3 times a week if you're doing brisk walking, you know, so that helps up your metabolism as well. So
That's
that
right.
actually helps to reduce your weight as well in the end. You know? Of course, other things as well. You can do things like yoga, because it's also women that have this disease actually go through a very stressful life as well. You're talking
Right.
about thinking of what, I mean, like going through issues like why my periods are not coming, why am I not reducing weight. They actually go through anxiety, depression, and all those things. So this is another thing that which they can actually go, yoga, doing group exercises,
Right,
you know,
something
Zumba,
that makes it
something that
fun.
makes it fun for them. So
Right.
that reduces their stress as well in the
Okay.
end. So it's basically starting off with a little bit of your lifestyle changes, not
Right.
being sedentary anymore.
Exactly.
Doing a little bit more of, you know, workouts and all that, which will definitely help.
Right.
Of course, over time, if that doesn't work, that's where we come in.
Right,
Right.
exactly.
Isn't it?
So in general, what would be the process, Dr. Bheena? Just walk us through the steps of what you would take when a patient presenting with Pcos comes in and the test confirms she has Pcos. What would you do next?
Okay. Of course, my first advice is going to be weight loss.
That's right.
All right. I do suggest them to actually go online these days, where you have support groups as well, especially on
Right.
Facebook and all that.
Communities as such.
Community as such, right? Because doing it alone sometimes is a bit difficult.
That's right.
And family members, yeah, most of the time they're very encouraging, but they don't go through what the patients are still going through as well. all
That's right. So they may not be able to share the same
Same
perspective.
perspective of
Right.
it, right? So you have support groups online, you have groups, I mean, you can actually join or colleagues and have a team and go
Right.
through your weight loss program together. Actually, that would be
Right.
the first thing that I advise them on. Next comes actually in terms of once that insulin sensitivity, which I talked to you about, the high levels are confirmed.
Right.
It's basically an anti-diabetic drug. It's called metformin.
Okay.
All right, but it helps basically to reduce your insulin resistance.
I
So
see.
eventually there is a link towards regularizing your menses, as well as it's also used in terms of ovulation as well. So that will be the next line that we would actually give them. All right,
Right.
metformin to help. Indirectly, it also says that, you know, it sort of reduces your appetite and all those things, and somehow or other it helps in terms of weight loss as well.
Right.
All right,
Okay.
so that will be there. Now, if while the process of main thing again is back to lifestyle,
Okay, yes.
medication. So
That's
while
the core of it.
core of it, right? So while they're actually doing this, then we can give them other things depending on whether they want to get pregnant, they don't want to get pregnant. That's also
Right.
the thing, right?
Okay.
So let's put pregnancy away. Let's just say they don't want to get pregnant.
Okay,
all
let's
right?
focus on that first.
On that first. So in that sense, then here comes the birth control pills.
Okay,
Birth control
right.
pills are not only used for birth controls, it's got multiple functions.
Absolutely.
All right. So one of the functions it's used for is actually to regularize the cycles.
Yes,
All right.
correct.
So it mimics your cycles with the estrogen or hormones, progesterones, and all that. So most of it, we will start them off on the birth control pills. The main one in there will be the anti-androgens.
Okay.
All right. The anti-androgens in that birth control pills will actually help out in terms of the hirsutism as well.
Right.
Right. So in 2 ways, it actually tackles that. All right. Now, over time, if it is such, resistance, patients still don't or they can't reach the goal of their weight that they
Right.
aim or
Okay.
we want them to achieve, then there's the extremes of actually doing bariatric surgeries as well.
Okay, I
All right.
see. A bariatric surgery, of course, is basically to have tubal ligation for your stomach so that you are able to lose weight easier.
It's basically a ligation of your stomach. Yeah.
Right.
Right.
Okay.
Exactly.
Now, how effective is that in cases which you have seen, doctor?
Okay. Bariatric surgery, of course, it's very helpful. If you look at it, patients actually lose a lot of weight. But
Right.
the process prior to that,
Okay.
all right, and the process after that, you need a lot of monitoring. So you're talking about thinking of an obese patient going under the knife,
That's
whatever
right.
said and done. So the complications of anesthesia, the complications of a difficult surgery, all those things that we actually have to think about before
That's right.
getting them to go for the surgery. All right, and of course, once you ligate the part of your stomach, whatever you eat, most of the nutrients
doesn't reach you.
Doesn't reach. It's not
That's
absorbed.
right.
So
True.
then you're thinking about complications in terms of absorption after that. You know, pernicious anemia, all kinds of anemias you can get as well.
That's right.
So most of the time we try not to go to that drastic end.
Right.
So it's always going back to the core thing of trying to lose weight, getting them on medications first, you know,
Right.
and get the cycles back to regular. There are women who said, "Oh, doctor, I can't." You know, so
Okay.
eventually,
Flat out, yeah.
So eventually, in the end, I advise them, okay, fine. If you can't, at least get your cycles, as I mentioned earlier, 3 to 4 times a year, so that you don't end up with long-term consequences of a cancer in the end, your
That's
lining
right.
thickening, and as well. All right, and of course, changing their habits to prevent your metabolic syndrome.
That's right.
So
Okay.
that's also important.
Right. Now, how common is it, let's look at the other flip side of it. Let's say there's a woman who wants to get pregnant
All right.
and she has Pcos and she has been having difficulty conceiving. Now, what would your best recommendations be as a clinician?
In these women, of course, time is an issue as well, isn't it?
Right.
If we tell them, okay, go and lose weight alone and come back, it's probably not going to take. It might take a bit longer than expected. Isn't
That's
it?
right.
All right. So we do help them out as well in terms of medications as well. So we have ovulation induction drugs out there.
I see.
Yeah.
Right.
Of course, the main aim is to tell them healthy, reduce weight, come back, and this is going to help in terms of ovulation as well. Because we
Right.
don't want somebody who's starting off pregnancy being very obese itself. So that
Also
can,
very true.
yeah, that is very dangerous as well. All right. So the ovulation induction drugs, there are clomiphene citrate, there are femora, there are different ones, which literally what's going to happen is it's going to stimulate your immature eggs.
Right.
So
I see.
yeah. So that's going to literally grow your eggs, and through ultrasound we will monitor the growth of those eggs, all right, and to a certain level when they've come, we say it's around about 2 centimeters, somewhere around that, where we
Right.
actually give another drug to help them ovulate. So it's basically going back to drugs, but it helps them to ovulate and then try for their pregnancy.
Right.
All right.
Okay.
If these drugs don't help, then it's going back to the next line of surgery as well.
I see.
All right, which
Okay.
means a simple procedure is done where through laparoscopic keyhole surgery. All right, we look at the eggs, where you see that multiple string of pearls, which I mentioned
That's right.
earlier. Right, we actually sort of make holes on that.
Right, on the
All right?
surface.
Yeah.
Okay.
So, that actually helps to reduce your androgen levels, and
I
in
see.
fact, in the end, hopefully ovulate as well. So that's
Right.
the next line.
Okay.
Out of which, in the end, if none of that works, then literally you're talking about doing in vitro fertilization. That
Okay.
will be the last resort of all those things.
Right.
Yeah.
But that's interesting to know as well, because that tells you that IVF is not the only option out there. Definitely not. In fact, as Dr. Bheena says, it is the last option in a long list of available.
Both deals, yeah.
Right. Okay. Now, let's speak a little bit about, as we've been talking about treatment. Now, is there something like a cure for Pcos?
Unfortunately, there is no cure for Pcos.
Right.
All right. But it is basically going back to all your modification of your lifestyle to actually reduce your symptoms or get back to near normal as possible. That's
Right.
about it. So there's no such thing that, oh, once I've lost weight totally, I'm not going to have Pcos with me anymore.
Oh,
No.
right.
There will be that. The ovaries will still have your cysts, or and at times it can function as irregularity as well.
Right.
But going back to that near normal, that's about what we can actually achieve.
Right.
That is,
Okay.
yeah.
Now, let's say if you are the atypical 10% of women who does not have the whole host of signs and symptoms, but you also have Pcos.
Right.
Now, how would it be easier for them to manage living with Pcos? And do they have a higher chance of living on the bottom end of the Pcos spectrum?
Most of the time, these atypical ones, there were no issues actually.
Okay,
So their
right.
cycles are usually regular. All right. They don't have problems with their periods and all those things.
Right.
Maybe at times they might just have difficulty, a little bit of difficulty in getting pregnant or something like
see.
that. That's when they come to seek treatment.
I
But
see.
most of the time, they just don't. You don't figure out.
Right.
So they just go on with their lifestyle as usual actually. So they are basically normal.
Right.
Right.
Okay.
Nothing to
Interesting
worry.
that. Now, on that note, another quick commercial break and we'll be back shortly. Stay with us. Welcome back to The Nation, still with Dr. Bheena and myself, Tamina Kaushi. Right, Dr. Bheena, so we were speaking about all the types of preventions and precautions that women living with Pcos can take. Now, are there also any alternative therapies or naturopathy cures that are also known to work in assisting women who do have Pcos?
Actually, there are many things that are being tried.
Okay.
If you're talking literally, you're talking about acupuncture being tried actually to regulate cycles as well, in terms of regulation for fertility as well, and to increase their fertility. You're talking about herbal medicine, Chinese medicine that can be used as well. But all of this, if you ask me, maybe just using one might not actually help throughout the whole thing. So a combination of things will actually help these women. So doing probably acupuncture plus a little bit of your Western medicine as well will actually help regulate your cycles in a way. All right. But I can't for sure say that yes, that all the other things actually work as such, but a combination. Why not alternative medicines to actually help out in terms of Pcos?
Right. Good to know. Good to know. Now, what would you say is the social impact of Pcos? Now, is this something that only affects women just because it is, of course, experienced by women, or does it go far beyond that?
Well, it actually starts off with the women. It goes off to impacting the families as well, and of course you're talking about workforce as well in the end, right? Women in the end, as much as I've said, they actually go into anxiety, stress, depression, because it's a long fight for them, literally, right? Because it doesn't, as I said, there's no cure.
That's right.
It's just going back to near normal as possible, right? So it tends to affect the emotions on and off all the time, right?
Right.
So having a very good support, I think, is important. That's where not only the women, family members, you're talking about husbands understanding, all right, giving them, or family members, let's put the Indian culture itself, all right? Where once you get married, not being able to get pregnant is a taboo. For them, right? Exactly. So things like that, where they need to actually be a little bit more sensitive to it, right? Exactly. Also looking into, you're talking about sleep apnea, irregular cycles, heavy bleeding, when they become tired the next day, that also affects basically whatever work you're doing, isn't it? The outcome of yourself, your production, the company's production, or whatever work that you're doing, also their long-term effect as well. So the social impact doesn't go only to that lady, but I think it affects everybody.
That's
when
right. A wider community,
a wider
family.
Community, right? That's why I mentioned about support. Support groups and all that, which is quite important in actually these women. So getting friends, getting family members, husbands, your relatives, everybody should understand that she's just not obese. She's going through something.
That's right.
And it can take a toll not only in her physical health, also her mental health as well.
Right, true enough. Now, typically speaking, what would you say is the recommended schedule for checkups, just for everyone out there, just from a gynecological perspective, just to ensure that everything is right and you are healthful as a woman?
In an average, say you don't have anything wrong, right? You don't have any symptoms, any
you
problems,
you
don't feel anything. I would suggest at least to do a yearly examination.
Right.
So yearly examination, you're talking about going through at least the basic cancers, the screening for cancers in women. All right. You need to do an ultrasound of the abdomen and pelvis, which means you're looking at your uterus, your ovaries, right? For those who have been sexually active, getting a pap smear done every year, all right? They say 1 to 2 yearly, depending as well.
Right. Okay.
To do your mammograms, all right, or your ultrasound breasts if you're in the younger age group as well.
Right.
So this will be the recommended schedule, not just leave them. All right. Then in the end, you find out that I've got some symptom, and you come up and you land up with some other cancer or some problems as well.
That's right.
So the recommended or suggested will be at least once a year.
Right, so once a year, ladies, so be sure of that. And to any men out there watching, be sure the women in your family are also taking care of their gynecological health in addition to other physical aspects. Right. Now, let's say if a woman is pregnant with Pcos, what are some of the complications during the pregnancy as well as for delivery that may arise?
Okay. As I mentioned, the first stage itself, right? I think it's quite common. You might hear that, you know, women will say, "Oh, I've got polycystic ovaries and I keep having a miscarriage." Right? Because of the higher levels of blood sugar within them, right? So that tends to lead to miscarriages. That will be one of it, all right? Or you're talking. The other thing will be actually eventually high sugar levels being unable to control, all right? You get diabetes in pregnancy as well. That's called gestational diabetes, all right? That could lead to abnormal babies. You're talking about neural tube defects, which means spine defects, brain development defects, heart defects, those kind of things, all right? Besides affecting the baby structurally, you're talking about large for gestational age babies, which means the babies are just too big for their expected weight.
I see,
right? So when you have a big baby, you're thinking of long terms again, right? Whether can they deliver normally, all right? If they can't deliver normally, if they're too big, can the mother hold the pregnancy long? Are they going to actually go into a preterm labor? That is another complication that can actually arise, preterm labor, yeah? If they go into labor, is the baby going to come out? Are they going to land up in prolonged labors? You know, because a bigger baby takes a longer time to go through the pelvis to actually come out.
That's right.
Or the fact that can they come out at all? Do I need to go in for a cesarean section? So landing up in a cesarean section is also another complication.
Right, exactly.
Now,
it's not ideal.
It's not ideal, right. If they go through labor, then there's also a risk of shoulder dystocia, which means babies with mothers who are Pcos, having diabetes, will have a broader or say a more fat deposition on the shoulders.
I see.
So the head might come out, but what can happen is they can actually get stuck on the shoulders. So that is another complication that can actually arise in these patients. So the main thing that we advise when moms with polycystic ovaries actually get pregnant in the end, whether naturally, spontaneously, or through your IVF and all that, is to go back and get your sugar levels controlled.
Right,
all right?
I see.
Which means going back to your diet again, all right? Changing your diet, reducing your carbs, all right? Or your sugar contents, your sugar intakes again, all right? Having regular monitoring of your sugar levels. That's another important thing as well. So to make sure that there is a limit, a certain range that we want them to be
your daily ideal intake.
Your daily ideal intake. So that will be their main goal as well.
Right.
Most of the time, a dietitian is always involved in their management as well, so they can tell them what is the ideal intake, what you should take, what you should not take as well at the same time. All right. And finally, what is emphasized is again weight gain.
Right.
So we try to tell them not to get put on too much of weight. So that's going to again be a big cycle. So weight gain, poor sugar control, and all this complication, a big round.
It's all just, you know, interrelated
again, right. So an average weight gain in pregnancy, you can go up to about 13, 15 kilos for an average person. But in diabetic or obese women, we're talking about going all the way only to about 9 kilos. Somewhere. So
the range is different.
So we sort of go around that, go around their diet, and then make sure that it's all controlled to prevent all the complications that can actually arise.
Exactly, right. Now I think it's been very detailed, and I hope that all our viewers out there have gotten as much as we have about Pcos, the signs, the symptoms. But as Dr. Bheena recommended, how often should women go in for a test, for a checkup?
At least once a year.
At least once a year. That's right, exactly.
And not only in terms of screening for cancers in women, I think everyone should actually go in and probably do a general health examination. So in terms of getting your all your examinations, your full blood count done, your cholesterol levels, checking for sugar, diabetes, you know, and the older age groups, I think women above 45 should get the stress tests done as well.
Exactly.
To see whether, you know, the changes during your heart, during that stress levels and all that. So it's not only men, I think more men tend to do that than women these days. So I think we should head towards that direction. So precaution, isn't it?
Exactly.
Than going in for cure.
That's right. All right. So thank you so much for your time today, Dr. Bheena.
You're welcome.
So this has been Dr. Bheena Vyshali Karunyam, who is consultant obstetrician and gynecologist, speaking to us about Pcos on the Nation. I'm Tamina Kausti signing off. Do stay tuned for our further programming.